Thank you. If brevity is the soul of wit, then I'll try to be very witty in introducing Don Frush. So his name is very familiar to many of us through Image Gently. He's a professor of both radiology and pediatrics at Duke, and his topic today will be meeting the medical needs of the nation. So, Dr. Frush.
Okay, the green is forward here. Great. Thank you, and it's always an interesting position to be last, and I'm not sure if that means that I'm dessert or washing dishes. And I guess I'd have the program committee to thank for that, but I'm on the program committee, so there you go. I also have to apologize for one thing. This talk will deal almost exclusively with diagnostic imaging. Obviously, radiation therapy is part of meeting the medical needs, but that's not what I do, so I apologize ahead of time. Although many of the things I talk about have some relevance, it's not entirely covered by this material here. I'm going to provide you the landscape of what medical imaging is and related to radiation and our understanding or lack thereof. So increased use, radiation exposure scrutiny, misinformation or misunderstanding, radiation guidance, accreditation, et cetera, the regulatory part, dose monitoring, emergency response, risk determination are all topics that we have to deal with. So we've not been successful stewards of radiation protection and knowledge. Overall, I would say that we've not been good at branding this, whether we misspell China or not. The fact of the matter is that we do have to take increased responsibility for many of these things here. Now, if you go back 100 plus years, I think these kinds of injuries from a skioscope, you notice the scientific content here, the fact that this isn't a medical journal and says he's okay because his hair grew back, probably wouldn't pass scientific scrutiny right now. But the fact of the matter is we continue, whether it's through personnel error or equipment error or just a general misunderstanding of what we do, we're called to public accountability for what we do. And because of that, there are many needs that we have. So we've not been successful stewards, and there are multiple stakeholders. If you think about what our environment is, it is intimately involved with everybody in this room in one way or another, some more than others. And we've not talked about the administrator aspect. We've not talked too much about industry, but these are critical partners in terms of fashioning, defining what our needs are, and developing strategies to meet those. So increased use, you all are familiar with this. There is additional information with pediatric imaging, what I do is you look over periods of time and you can see, based on the kind of examination in the year here, the increase in use over the past couple of decades. Now, things have sort of tapered off a little bit, but it's still clearly more than we did even 10 years ago. If you look not only at the amount we do, but the range of doses that are provided, at least for children, you can see here, for example, in the teenage group that the range of doses was pretty substantial. And while we need to have a range, there's not simply one dose estimation that's appropriate. Most would agree that this degree of difference is not within expected practice. So increased use, radiation exposure scrutiny. So this is the front of a book by John Steinbeck that's called Travels with Charlie, written in the 60s, and he aptly said, "We value virtue, but do not discuss it. The honest bookkeeper, the faithful wife," and I had to add husband to this to be politically correct, "the earnest scholar get little of our attention compared to the embezzler, the tramp, and the cheat." And that's entirely true with radiation protection and what we try to do. In a simple word from the scientific community to the media, that we are doing damage to our patients and we're not good stewards of what we do, gets a whole lot more mileage than the balanced information here. So even 55 years later, we struggle with these things. And this is Travels with Community Reports. So we had Travels with Charlie, this is Travels with Community Reports. And as John alluded to, this kind of public scrutiny balanced or not, is what carries the day, irrespective of what you try to do from a publication standpoint, from a website standpoint, et cetera. And I'm going to return to this when we talk about strategies. And these are the kinds of emails I get. So Dr. Frush, our 6-month-old, pulled a cord off, got his head bumped, had some skull x-rays, and then a CT scan, and arguably the x-rays may or may not have been useful, but I never get into that. And this is the kind of thing that happens routinely. So we get inquiries from the lay public. And then we're also dealing with the media aspect of radiation protection and understanding too. And so there is increased scrutiny. Now, misinformation and misunderstanding. So here are 2 of my children. I probably have higher radiation exposure than most people, and I think they're just fine. So all of this is entirely overblown. But what has helped to overblow that are articles such as this. This was in USA Today now in 2001, and it simply misstated the facts. There was no equivocation, there was no possible, there was no potential. It was simply that 1,500 of the children are going to die from a single CT examination they performed this year. Now, the plus side of that is I think it was provocatory, it was inflammatory, and it caused a great deal of change throughout industry, administration, throughout the scientific community. And while this isn't a sentinel article, it is really important, partly because it put pediatric radiology between the president and the Pope, right where it belongs. And this is what we have to deal with. These are medical practitioners. Now, how can you not react to this as someone on Sunday morning drinking a cup of coffee, reading the Times? More recently, a physician said as many as 1 in 300 children who get a CT scan of the abdomen, chest, or spine will eventually develop a tumor as a result of radiation. There's no equivocation here, okay? That sells the day. That sells the internet, that sells papers, et cetera. And from an individual I won't name, but a discussion a few months ago, this individual said it's certainly a consensus opinion that there is harm at low doses. Okay, that's a major accrediting organization. That's what we're trying to deal with here. And this article by Merv Cohen at Riley in Indianapolis is a nice article because it outlines some of the media over the past 5 to 10 years and how they've responded to this and so on. And I just provide this as a resource. But if we talk about general risk literacy, and I'm talking about putting information out to the public, and the public's understand, or patients or their parents, but how do we do as physicians? This article summarized some data in a meta-analysis and said radiologists, the imaging team, should prioritize development of consensus statements and novel education initiatives, blah, blah, blah. There's just a lot of words here. But this is really interesting because this is a table asking physicians about whether ultrasound and MR use ionizing radiation. And you can see, depending on the study, 5%, 30%, 30% MR. These are physicians. This study came out a year ago. So we still have a long way to go in terms of literacy, not only getting the message out to the public, but getting the message out to our own practitioners here. So what are some of the recommendations? PAC7 is going to be vital here. We just need to move ahead with this. Formal communication networks to avoid redundancies and identify gaps. We don't need 28 different agencies all kind of doing the same thing. Nobody has the money to do that. And for example, there's an imaging communication network through diagnostic imaging that involves the American Board of Radiology, the American College of Radiology. I think NCRP is on that. So when an item comes up, instantly that network is aware of it and can respond and begin to fashion statements and so on. And I think it's been very successful in the 5 or so years. I think Jim Brink was one that thought this up. What else do we need? Global efforts. Again, there are lots of global initiatives that are happening. Image Gently, Image Wisely you've heard about, but there are additional European, South American, and East Asian groups that are working towards these things. And it doesn't make sense to have all the groups fashion their own material, create their own websites and so on. So the communication and interlinking of these for resource optimization is going to be really important. And that's beginning to happen, but it is certainly not complete yet. And we talk about the consumer report issue, as John Boyce alluded to. We went up and met with them, and I would say there were probably a dozen to 18, every 6 weeks or so, another paper came out with, do you see what we're doing? We're wasting radiation, and not only is it an unnecessary test, but we're actually probably killing people with it. And this continued paper after paper, city after city. We went up and talked to them. There was one after that time, and it probably was in the works before we went. And so that sort of education and communication was extremely helpful in terms of getting a balanced message out there. Patient advocacy groups, I know from Image Gently we've not developed this as much as we have. There's tremendously strong voice. Align with communication experts, develop social media strategies, institute medical radiation programs. And an example of what we've done at my institution at Duke is we have a interdepartmental radiation center that has research interests as well as credentialing, and it involves radiologists, technologists, medical physicists, health physicists, engineering, radiation safety officers, other than health physicists, administrators, cardiologists, radiation oncologists, gastroenterologists, emergency physicians, IT experts, urologists, orthopedists, and vascular surgeons. When you see the broad landscape of all the supplies. So we talk about radiology being the most relevant, and maybe it is or maybe it isn't, but all of these groups use radiation in some fashion or another, and is it done the same, or is it the same sort of regulation? So we've been successful, particularly in handling some of the Joint Commission regulations and some new CMS kinds of issues that come up that require a single institutional lead for all diagnostic radiation. Content is real important. This is going to be a document that comes out through the World Health Organization. I think the release is April 22nd, so keep an eye out for that. It was 5 years in the making. Image Gently, Image Wisely, one for adults, one for children. You need to remember, though, content is important, and there's a lot of content in this room, but delivery is important too, okay? So the content is all here. Here's a guy with a bat, and there's somebody throwing a ball, and people are sitting around watching it, many of whom probably don't remember because they've had a little bit too much beer. They're in a ballpark, and so it's all there. The content is the same, but this is not the way it's supposed to go. This is bad delivery. So delivery is equally important in how we get this across, and that's why the communication expertise is critical. And finally, we have to emphasize the value of CT. We talk about radiation, we talk about radiation injury, and we've not been good stewards at emphasizing the value of CT. So I put a study up here. This is a nice young man. He was riding back home out in northern Durham County, and he was hit by a truck and came into the emergency department. And I've circled things here. We all wish as radiologists that the images would pop up with things circled. And all the yellow here, let's see if I can get the light. So this is, these are both legs. That's his pelvis, that's his arm. This is active bleeding in his left knee. This is active right knee. This is active bleeding. See that white there in the left knee? This is active bleeding in his arm here. And he required 14 units of blood during the time he was stabilized in the emergency room. And this is active bleeding in his abdomen. And the trauma surgeon was sitting next to me as these images came out. And he said, this CT saved this individual's life. There is no question that he would have gone for an orthopedic procedure because he needed to stop these active arterial bleeds. But he needed to go and get his abdomen stabilized first. So now you have, this is one proof that CT saves lives. And every radiologist in this room can give you another example. Where are the data that someone has died from a CT examination? So we talk about this, but this is the reality, and we need to emphasize the value of what we do. And we've not been very good at that as a medical community. This is the car that hit him, okay? And this is, can you all see it? That's the motorcycle. It's not, over this side. That's not very damaged. This is where his head hit the windshield, and unfortunately he was wearing a helmet. That's a lot of trauma. And he's doing okay. He's got some orthopedic injuries, but there is no question of the value of CT, and that's the message that we need to keep on, and we need help in doing that. We need media experts, et cetera. We can't do that as physicians alone. Increased regulation, accreditation, and guidance. Joint Commission came out in 2015 with new diagnostic imaging standards. Some of those standards were that we have to monitor what we do and have periodic reviews and so on, and much of it is reasonable. It's created a lot of work as we build dose monitoring programs. NEMA came out with some additional requirements for us that are based in billing, and if you want to change practice, paying less for what you do is a way to do that, and so those are some other regulatory standards. The EPA and subsequently CMS have come out with new regulations too about what institutions and practices should have in terms of radiation programs. So there are many, many regulatory guidance, accreditation forces that we have to respond to. So we, as a community, need to be involved in review of the proposals from these groups, establish communication networks, and have support for medical physicists, technologists, support for IT. Support is a word that's going to come through a lot. This isn't free, and people don't have a lot of time, so it's going to be support. Dose monitoring, I'll go through kind of quickly. This is one way to monitor doses. You give the parents a card and you ask them to put the examination in there and so on. And I don't think this is the responsibility of the parents. They ought not to be doing that. So our state took over this responsibility and sent this memo now a number of years ago. And I'll kind of paraphrase it. It just said, you've had a lot of CT scans, you've had 10 scans, and may be at risk for cancer. So you should contact your physician and discuss this with him or her. Now, what's a pediatrician or a family practitioner going to do with this? They're going to go, I have no idea what this means. And I don't want to go into detail about it, but the best part about it, only from a governmental agency, is at the end they say, wishing you the best of health. So there you go. Now, fortunately, this was retracted, but this is attempts at dose monitoring that are ill-founded. So the Joint Commission, again, I said in their new standards, has these kinds of things that we need to do in terms of CT dose monitoring. It's very complex in developing these programs. First, I prefer dose monitoring over tracking. Monitoring is what you do when you're watching for fires. You track a moose, okay? To me, it's not really what we need to do. Tracking is a bad word. We need to develop monitoring programs, and all of these are elements of monitoring programs. And just to cut to the chase, it's a very, very labor-intensive, data-heavy thing that we are asked to do now in terms of our CT examinations, nuclear medicine examinations, even dealing with radiography now in terms of the accountability for protocols and so on. It's very, very, very time-consuming. These are the fundamental elements of a dose monitoring program. We have to define the terms of the doses. It's the individual patient dose that we need to follow, as well as institutional trends. There has to be a recording process, a monitoring process. You have to define reports and triggers, and what measures you take to address those outliers and so on. And it's not something that we consistently did over the years, but as of July, everybody has to do this and answer if their hospital is going to get accredited to the Joint Commission. This is just an example of what our program is and how, based on the size of the patient and various CT doses, might be displayed. And when we looked at some of the issues that were involved in outliers, say outside of 95% dose range, how we were able to tighten that up by doing a dose monitoring program, and how on an individual scanner you can see the expected and actual doses anticipated for 3 different scanners, how scanner number 2 wasn't accurate, and how we identified that and went back and took corrective action there. These are the best practices for dose monitoring programs. Again, it's heavily information technology dependent. It's going to take a lot of engagement from that community. And one thing that'll be required are dose reference levels, or the diagnostic reference levels here, or DRLs. And I'm just going to move through this quickly because there's a lot of data here. And I don't want you to focus on this as much, just to see that this is the ACR Dose Index Registry, which is a large over between 15 and 20 million examination database now that we can access and get information on pediatric CTs, and we can see that pediatric CTs occur in like 60 to 70% of all pediatric CTs, the relative percentage of them, the doses that are provided by head CTs, abdomen, chest CTs, et cetera, and we can begin to construct what the practice is, what the expected, because that's the Joint Commission's language, what the expected range of doses should be. This hasn't been done up to this point. But, and I put this up because there are several papers, Rebecca Smith-Beinman, Marilyn Goski, and then presentation we did that shows how you can relate these doses together. This is in its infancy. It's very primitive here, and you would think that we would have had this well developed, but it hasn't been so far. So the dose reference, the dose reference levels are an important concept, but are going to take some resources. I'll move past this one. So medical physicist guidance, IT expertise, it's going to cost money. Industry partnership is very important. There are several products out there, none of which is fully formed and entirely error-free. It needs to be automated. These are all things that need to move forward. And so when you look at a dose monitoring program, it's really intended to have your institution, yourself, the program be accountable for what they do. That is providing good radiology services, quality and dose considered here. How best do you convey that to the patient? Well, there are some, the state of California requires that dose information be in the patient report, and I won't get into that, but I'm not sure that the patients really understand that nor want to know that. I would argue much more that your report should sort of good radiology seal of approval, as we did good housekeeping. How you do that is going to be institution dependent. The accreditation, the certification of the people that have developed your program, to me, are much more understandable by the public than some of the requirements that are coming through. Emergency response, I think you've heard the last talk very eloquently talk about some of the gaps and some of the needs. And I will say that even our institution, after the RSNA talk that individuals gave last year, I went back to our emergency response team and I said, where do we sit? Where do we stand? And on paper, everything looks really good, but in practice, any of you who've been in an emergency situation, in the emergency department, what you hear and what you configure as the true magnitude is usually entirely different than the scope of the problem and how it's handled. And downstream is radiology, and anything that's involved in a nuclear event or a radioactive event, the technologists, the radiologists, and so on, all they are going to be sitting in their CT scanners and radiography rooms and going with the portable scanners and saying, this patient's radioactive, I'm at risk. And that's really the fundamental problem, is a lack of communication. So we're beginning to address it at our institution too. We've also never had a mock radiation event. We've had plenty of train crashes, we've had biologic events, we've had chemical events. But when I said, has anyone talked about a device that sprays radioactive material? Well, no, we've not really done that. And those are important things to do, and that's going to be an important topic to address next year. So recommendations, again, that the annual meeting content is very important. Integration of medical experts and emergency prep teams. There's often a disconnect there, is a strategy. And response templates, so that everyone from the beginning, from the triage area, the decontamination area, to the emergency department, to radiology, has the same understanding of what this process is. And finally, in the last few slides here, risk determination. Is there a risk or isn't there a risk? Here's a paper that says CT scans are actually helpful, and everyone should have a CT scan and a latte and, I don't know, a massage. Here's one that says 3 chest x-rays have an increased risk of leukemia. I would argue that going to Myrtle Beach then has an increased risk of leukemia. These are published papers. And then this one, I think many of you are familiar with, that data are that there will be 1 new brain tumor for every 10,000 brain CTs in children. And some more balanced approach, or some more different information that called into question some of these earlier studies here. So from the radiology community, from the medical imaging community, this is what we have to deal with. So the recommendations, that's all I have to say is we need your help in this. We are not epidemiologists. We are not radiation biologists, and we look forward to the clarification as much as possible of how we communicate these things with our patients. So in closing here, and I know I've gone through things quickly, but one of the benefits is coming last, as you can say, you heard this before, this person talked about this, and so I just touched on many of these things. And there are many needs. There are many opportunities as well, and there are many stakeholders, much more expansive than I think at first blush, and it applies across all medical providers. Again, radiology is one part, but you saw a dozen or so different subspecialties that all have various understandings of what we need to do. So it's going to take money, as everything does. So thank you for your attention this afternoon, and I think we'll take questions.
Is my mic on? My light's not coming on. Can you hear me okay? Your example of the motor vehicle accident showed the benefit side of the risk-benefit decision process. This first question touches on that. It says we are pretty good at estimating adverse effects from ionizing radiation exposure. Do we need to get better at articulating the benefit of getting that X-ray CT exam? And are there resources to develop this and quantify this?
Well, the answer is yes, and that was one of the main parts as we're so inundated with risk and defense of what we do that we've not been good about getting the message out for the benefit of CT scan. And I would argue, how do you get that message out is a question that I sort of asked at our dinner 2 nights ago. How do you do that? The media doesn't want an article that says CT examinations are extremely valuable, they save lives, physicians are interested in doing things that are right and are willing to have discussions with you about the benefits of these examinations. No one wants to read that article. They want to know that CT examinations are actually harmful. No one wants to read an article that the police force is behaving responsibly. They want to read an article that says, there are drugs missing from a raid or that they're beating people up, and that no one wants to read an article that says college football coaches are actually decent human beings and treating their players fairly. They want to read stuff about, abuse, child abuse, and so on. That's what sells. That's what the media is all about. And I don't have good things other than we try to stay on message about the benefits of CT examination. We need to try to do that. We need to work through the image gently, image wisely. We need communication experts, and I would argue that we haven't been very good through advocacy groups at getting this message across, nor in social media. It's how the public functions now, and those are areas that I think we need to go into. But we're on the defense a lot.